Welcome to Grand Rounds. Thank you for your patience as I'm a little bit late and then just testing the IT. I think we've got about 35 people on the call today, so welcome to everyone who's listening in or watching. My name's Tom Forden, I'm the chair of Grand Rounds, and this is our penultimate Grand Rounds of the delayed summer semester before we take a late break. Next week, Jonathan O'Riordan is going to be talking about variants of optic neuritis and the presentations, complications, and some things not to miss. So for a clinical update on that, tune in at the same time next week. And then we're going to have a break of a couple of weeks whilst I have a bit of a rest, and we have some we can build up a new program. So if you have an interesting talk you'd like to present in this format, then please let me know. Just send me a message or an email, and I will give you a slot. This week, we continue our medical education theme with our fourth talk in the last couple of months about how we're going to cope with teaching medical students and doctors in training in this new world that is the all-encompassing COVID has taken over how we work and the ways we work and everything that we do. This week, Joe Sloan, who's recently appointed as the medical school fourth-year lead and consultant renal physician and general physician in Perth, is going to lead a group of 3 experts in teaching who are going to tell us about the challenges involved in particularly fourth-year teaching placements. But I think a lot of this is going to be applicable to all years of medical school and also teaching our trainees as well. On the call today are also Jonathan McCormick, who's a consultant pediatrician and veritable whiskey buff. You can see by the posters in his background. I'd be amazed if there isn't some sort of whiskey reference at some point in this talk. And Lysa Owen, who is down in clinical skills. So we'll start with Joe, who's, oops, you've got a visitor speaking in the back. So we'll start with Joe. If you share your screen, and I'll shut up and we'll see how we go.
Lovely, thanks very much, Tom. Nice. So as Tom has said, I have recently taken up the role as the Year 4 lead for our undergraduate medical programme. And I think this would have been quite a challenging role to take up at any time, but whenever you add in the global pandemic, which is COVID, there certainly have been additional challenges that we're facing. So today I'm going to really focus in on what those challenges are to kind of set the scene, to then pass over to Jonathan, who will discuss what will be a fantastic solution, I think, for many of our blocks in fourth year. And then finally, we will summarise with just a few kind of updates that you need to be aware of coming forward. Okay. So if I take you back to March 2020, you're all aware that all of our fourth and fifth year students were asked to leave their clinical placements. They had to go out very quickly as we redesigned our hospitals, as we redesigned our services, and Ninewells and all of the surrounding hospitals looked very different to what they previously had looked like. And what happened over the next few months was nothing short of extraordinary. Our teaching leads and our block leads developed a vast array of quite high quality virtual teaching activities, some of which were interactive, others were just resources and e-learning resources that were made available to our fourth and fifth year students. But we now have moved forward, and as of 2 weeks ago, our fourth years are back on placements. So you may very well have seen some of them coming back into our ward environments, although the numbers are still very, very small as they're undertaking their transition block teaching, and they're only coming into the hospital once each. But in the next couple of weeks, they're going to go out into their main blocks, and our fifth years are also going to return. So you're going to see more and more students coming into our clinical areas. And what has changed over the summer is that we have become much more comfortable with our new working environment. We've adapted our practice, we have developed proper PPE practices, and we've also recognised that our students are key workers and they have been granted key worker status. So if we do look at the challenges, fourth year pre-COVID was a really diverse year. There were lots and lots of different teaching activities that happened, and each block was very diverse in what those would offer. So there were tutorials across the years. and the tutorials mainly were face-to-face. Students would attend clinics, but the clinics would be much less timetabled activities. They would be signposted to these clinics and they would go. The students would need to find procedures and investigations that they needed to observe in order to get signage in their Rocky booklet completed. There would be theatre sessions that they attend, ward rounds and time in clinical areas such as the labour suite or A&E departments. So as you can see, there's a whole host of clinical experiences that our fourth years previously had access to. But going forward, it's going to look very different. I'm sure you've all heard of the blended learning term, and you will all hear more and more about that as the months progress. So our fourth year, our tutorials are now going to have to be virtual. And as I said, we already have quite a large bank of really high quality virtual tutorials made over the last few months. Students' exposure to clinic is going to be very different. You will all recognise that the clinics that are happening are much less frequent than pre-COVID. And those that do happen are rarely face-to-face. Most of them are telephone consultations or using near-me technology. And whenever we are carrying them out, they are often being done either from the clinician's own office or their home environment if that clinician is working from home. For procedures and investigations, the rooms that previously were adequate in size are now sometimes too small to allow 2 or 3 students in. Some of our procedures require PPE for aerosol generating procedures, and the medical school have made a stance that our students will not be face fit tested for the appropriate masks due to the impracticalities of this, because our supply chain does change and you'd have to repeatedly be doing face fit testing. And we still are doing kind of less of the routine work. We're still on an urgent and emergency footing, although I do appreciate that we are returning to more of a normal service. Our theatres have been changed into green and amber zones, and our surgical colleagues have had to make sensible decisions around about which students can gain access to these zones. Ward rounds have never stopped, but again, we've had to consider social distancing. So I think the days of having 4 or 5 students on a ward round are gone, and that may be a good thing in the long run, I have to say. Another challenge that stands out with of COVID is the number of medical students that we have in our years. So this year we have at the moment 179 fourth year students. But our fifth years who were asked to leave their clinical placements back in March are being offered catch-up time in the clinical placements of the missed blocks. So that equates to approximately 9 fifth year students per block. And overall, for each of the 10 blocks in fourth year, there will be approximately 27 students on each block. If we then look at the ScotGem programme, this year the ScotGem students have integrated with our Dundee fourth year. They will undergo the LIC component of the Dundee programme, and in that they will be based mainly in general practice. However, 9 students are going to be in Tayside general practice locations, and those students, although based in the GP locations, will negotiate exposure and experience within the secondary and tertiary care settings. So you will see these students coming in to engage with clinical activity going on within Ninewells and Perth. And then one of the other big challenges in terms of numbers is at the end of this fourth year, we are planning to assess the students' skills in the form of an OSCE. Now that is the plan at the moment. Everything is clearly under review, but you can see that the numbers of students for this fourth year OSCE will be quite large, and that does give us some logistical complexity when planning a socially distanced and safe OSCE. But one of the biggest challenges that we face may be the next surge, and if we do go into a further lockdown, what are we going to do with all of the fourth and the fifth year students? The GMC have come out with a very clear statement, which I think we will all find very useful because it gives us the permission to do what we all know is right for our students. So Professor Colin Melville wrote to each of the governments of our 4 nations, and that has been an open letter that is being shared with all of us. And I'm just going to read the components of that letter, which I find are most useful for us. So the GMC have stated to the governments, we're asking for your help to ensure that healthcare providers involve medical students as key members of their clinical teams, so key members. Students must be supported to continue their education and training safely alongside their prospective colleagues. We know this may be challenging if there are future waves of coronavirus or other disruptions to service, but it is vital that medical students are able to complete their studies and be assessed appropriately. Medical students need to continue their education in clinical training locations and be appropriately protected to do so. It is also crucial that organisations and the wider healthcare team help patients to understand the importance of medical students taking part in their care, so the health service can secure enough doctors for the future. So I think these statements are very clear. If we get a further surge, if we get a further local lockdown, our medical students need to continue their education in the clinical training locations in a safe manner. And therefore, I think at this point, we have several real needs that we need to focus on for our clinical parts of our training programme. And that is that we need to future-proof any teaching activities that we are designing and delivering, so that if we go into lockdown or if numbers increase, that we can continue to deliver that. And in doing that, we really need to focus in on targeting the high quality learning events that we really need our students to get access to. Now, I am generally a fairly positive rather than realistic individual. So this is my horrendous attempt at trying to depict the silver lining on the cloud. But in my my recent conversations with our block leads, COVID has not all been bad. It has actually enforced upon us a curriculum review that none of us could have predicted coming. There was a formal curriculum review process that we were nearly at the end of for the SIP component of our curriculum, but this has sparked the change that will be required for the ongoing development of our year 4 and 5 of our undergraduate programme. So that is me done for this part of the talk. I'm going to hand over now to Jonathan, who's going to hopefully give you a solution to some of the issues that I have raised in my component.
Thank you very much, Jo. Let's just see if we get that going. Okay, is that up for everybody? So the Child Health Teaching Clinic, I'm going to split this into before and after the pandemic, because it's worth seeing the journey that we've taken in developing this resource and why this could be a perfect solution to some of the challenges that we're facing. So I've been running a teaching clinic in child health for many years, and when we started it, we had around 2,500 outpatient clinic appointments in pediatrics every year. A lot of these were highly specialized clinics, and their students were sitting in on those. They weren't necessarily going to follow up those, they weren't necessarily core topics, but we had at least 50% of our 4-week child health 4th year block devoted to this outpatient experience. But here's the problem, and it's no different from when I was a Dundee medical student all those years ago. So if it's not about you, clinic can be pretty boring, and therefore sitting passively in the corner isn't an awful lot of fun. There are some clinics we're aware of where people say, oh, we don't take students here, we don't want students, and students have been turned away. You'll also be familiar with people who've handed a set of notes and say, go next door, take a history, and come back and tell me. We do that in both undergraduate and postgraduate, and at all points in our training, we'll have been familiar with listening through the doors to see if the boss has finished yet, knocking and waiting and hoping to get in. I think one of the problems with the way we've done outpatients that really hasn't changed for decades has been that it's quite a passive experience. You're watching somebody else work, you've got limited opportunities to actively participate, and you may get some feedback in your clinical skills, but generally you're watching and observing the general service rather than taking part in it yourself. The big thing that has changed is that the way we did clinics before, you gave you a 5-minute breather in between patients where you were able to cover what you'd seen with that patient in confidence with the student. You could do some teaching, ask some questions. That time has been squeezed almost to the point of non-existence, because in between patients now we need to do ICE requests, track care outcomes, outpatient communications to primary care colleagues, write any prescriptions. Some people may do their dictation as well. So there's very little time left for teaching before the next patient is due in the clinic room. So we were trying to respond to the outpatient feedback from our fourth year students, which really reflected all these problems, that some people didn't get in through the door, some people weren't getting a chance to participate, and it was not really fulfilling their educational needs. So the teaching clinic format that I used involved direct observation. It was learner focused, learner friendly environment. This was designed for teaching rather than for clinical service. And it is incredibly rare for fourth years to take a whole history and do an examination in front of a consultant and get tailored feedback on their performance. So it was designed to eliminate that conflict of service delivery and time pressures and numbers and the IT systems in order to focus on teaching the students. And I felt it was very important to deliver an authentic experience with teaching with real patients rather than actors. So if people bring 4 or 5 other siblings who are very noisy and run around the consulting room, that's real life and that's what happens. So the version 1 or 1.0 was a fortnightly clinic, and we filleted out new patient referral letters from the pile, and they were invited to come to the teaching clinic. We set about a 45-minute appointment, and that was to give sufficient time for the student to take a full history, examine the child, make a plan, answer any questions, and then do some teaching in between time. Because young children can be spooked by meeting lots of new adults, we kept it to 4 students maximum in the room. And that meant when we had 16 students in the block, and we were running 2 of these per block, that we were teaching around half the students every block. The other students that weren't taking the history were there to provide constructive criticism, observe, sometimes pacify other siblings, and jog them memory if the history taking faltered in any way as they went along. So these, I think, are the 10 key educational elements that I felt were important in that teaching clinic format. They got to take a supervised structured history. This was really good OSCE practice. They learned how to control the consultation, use open and closed questions if the historian either gave too much information or too little. They knew when to involve the child in the history and when to back off and leave them. We taught them how to use a recap and a summary, which was a really essential OSCE skill if you're very nervous in OSCEs and tend to rush through and finish with 5 minutes to spare. Using a recap's great to reboot a stalled brain and get going again. It allowed us to build confidence in clinical examination skills because you could be examining children of any age group. They really valued the tailored feedback, and I remember specifically doing a teaching clinic once with 2 mature students who'd previously worked in other occupations. One worked in as a primary school teacher, and the other had a paramedic background. The paramedic asked lots and lots of close questions, and it was bang, 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 trying to get as much information as they could, and they really needed to soften their bedside manner a little bit to get a fuller picture. Whereas the person with a primary school background needed to sometimes have that skill to focus in and ask some of the closed questions. So they learned really well from each other, and we would never have learned that if we hadn't had the time to develop that. We look at clinical reasoning, working through a differential diagnosis and the appropriate use of investigations. In between the patients, I would thank the family, discuss the diagnosis, arrange follow-up, etc. And then the students were asked to criticize their own performance, as were their peers, and we would build on that with the next patient and the next patient. So by the end of the afternoon, they'd gone on a journey, they'd all learned new skills and left feeling much more confident about taking histories. And they left with things in their back pocket that they could take to the OSCE and really use. And that seemed to be very, very valuable. For the patients and families, yes, they were longer appointment times. They were all told in advance because they get a specific letter inviting them to the clinic, telling them that there will be students, but they were guaranteed to see a consultant, and we found the opt-out rate was very low. But the problems we could run into from time to time were, it's annoying if somebody doesn't turn up for a 45-minute appointment. We tended not to use patients that also needed an interpreter. They went to the general pediatric service, and occasionally finding sufficient suitable referrals was a challenge. So we got excellent feedback from those that came to the teaching clinic, but we also found that word was spreading, and those that missed teaching clinic or weren't timetabled for it weren't very happy with that. So we came up with version 2, which was the video conference teaching clinic. And here we used a mobile video conferencing unit to solve the problem. We were able to double the student numbers and ensure that every student on the child health block was included. And we could do this without any increase in staff resources. And as the equipment was there through the NHS, we didn't have to purchase any additional equipment. So this is kind of how the teaching clinic looked. The student is in the chair taking the history from the parent and the child, and you can see the video conference unit in the background, and it's broadcasting like shortwave radio through the wall, because behind that yellow cupboard there's another room where there are additional students sitting there. I would normally sit in that empty seat behind and take notes and tips for the students. This is what it looks like from the students' room. So this is again pre-social distancing, and they're watching the encounter on the video conferencing screen. So we used to get lots of really good feedback saying that this was excellent. We wanted more of this. In fact, it was the most positive teaching feedback that we got for the whole child health block, and we have expanded it. So my colleague Linda Cleryhue has also joined and done teaching clinics so that we could run 4 per block now, reduce the student numbers back to 4, and try and provide a patient for everybody. So it was old-fashioned teaching because it was bedside one-to-one teaching, if you like, and we were harnessing that power of the technology to make that work. We were using feedback to stimulate new ideas. And I must admit, this wasn't an original idea, because there was a similar clinic format that John Dent used to do many years ago that he published nearly 20 years ago in Medical Teacher, saying that a specific teaching clinic format could drive up the quality of outpatient teaching across many different departments. The video conferencing element just allowed us to provide more opportunities to more students. So our mantra for teaching clinic is, you can't always learn to drive if you're always the passenger. And you can learn to drive, you can't learn to drive if you haven't got an instructor in the car. So the best place to be is at the driving seat, and that's where we aim to put the students. So that was all before, and then after the pandemic, we were trying to see where this format could provide a solution to the difficulties we've got with student access to clinics. So there are much fewer face-to-face clinics across the whole service, and everybody's keen to make sure that only essential staff are involved in face-to-face encounters. There's a lot more near me appointments and phone clinics. PPE is being worn in clinical and non-clinical areas, additional consideration, and there's a great fear of patients coming to hospitals. So potentially this cartoon would show how we could do a specific teaching clinic using Near Me that would enable us to teach a larger number of patients. So imagine the patient is on the left there having a Near Me appointment, but the history has been taken by the student who's driving the encounter, and they're also joined on Near Me by the tutor or consultant. Now, you can only have a limited number of participants on Near Me, so we can't have the entire group joining, and if anything, that would be very daunting for the patient. What would be possible, though, is to bounce the tutor's screen to screen share onto Blackboard Collaborate, where a larger number of students could be watching from a room socially distanced, or from multiple locations socially distanced, so they're able to see and participate in the encounter. Similarly, if students were going into face-to-face encounters in a teaching clinic format, they would be taking the history, the tutor would be in the room, and then through using technology would be able to share that encounter with a group of patients. So that's, if anything, more similar to the video conferencing teaching clinic. And basically anywhere where you could take a camera and share and connect the technology in this way would enable you to do that. So you could take a camera into Breaking Bad news encounters, or to theatres, or child protection work, or anything across any department potentially. But I think the key elements to take away is the fact that it needs to be built. It needs to be a dedicated teaching clinic, not just bolted on to the existing clinical service or using actors. I can't stress enough how important it is to use genuine patients and genuine encounters, and it makes all the difference. Given the fact that screens are shared, patient consent to the format would be essential before they're involved to maintain confidentiality. We need to offer advantages to patients that, we can not have long waits to get to one of these appointments, and they will get access to a consultant. Tutors can use Near-Me and Blackboard Collaborate simultaneously if they're using two systems. We need to carefully select the students taking the history so that people aren't too concerned that they might fail in front of all their peers, and that they're willing to participate. The encounters shouldn't be recorded, but real-time video again for confidentiality, and we need sufficient space for students to have small socially distanced groups. When I initially pitched the teaching clinic format to a number of other groups, the difficulty we had in the adult outpatient services, there was not enough space. With the screens, we can get around that because we don't need the physical rooms in outpatients. The students must be able to interact and ask questions, and as before, the tutor still has responsibility for managing the diagnosis and follow-up, etc. So teaching clinics would allow us to build in high quality teaching, allow us to expand this into other areas of the fourth year block, and potentially export it not only to other departments, but other medical schools as well. Consent, confidentiality, and learning are the key things to make this work. We need to ensure we've got the physical space where confidentiality can be maintained, and the support from Tilt through the university to ensure it happens. But I'm keen that not only people look at building a teaching clinic into their fourth year, that people become teaching clinic evangelists and take this into all sorts of other areas of their blocks and their teaching, so that it can be adapted for a wide variety of other teaching sessions, and stop at outpatients being the passive sit in the corner and be quiet experience that it sometimes is. So I will now stop sharing and back to Joe.
Thanks, Jonathan. Now, so kind of moving on from what Jonathan has said, this idea, as he has also mentioned, can be used for any of the clinical activities, so ward rounds, theatre sessions, procedural lists. So what we've been doing in the background, in conjunction with conversations that are ongoing with our block leads, and in the context of having sent out a needs assessment to our block leads, the medical school office, headed up by Cara Knight, who's our medical school manager, have formed a team of all the individuals who we need to be at the table to make this happen, to give clear consenting guidelines, to have physical space for our students to come into the hospital in order to access these clinical events. There have been conversations as to whether or not we would feel comfortable with our students accessing these from their home environments. Most leads don't feel that that's appropriate, and therefore we are trying to look at where the room would be that students can come and sit in. We're working with our e-health colleagues, our information governance teams, Tilt, bringing together the IT components, the storage and sharing of data components, and also the Director of Medical Education team, looking at our timetabling processes, so that for you as clinicians, it's about coming coming up with the idea, looking at where you can use this sort of concept in your teaching, and us developing and delivering to you the how-to guide so that you can bring together your patients, your students into a teaching event from whichever clinical space your patient is in. So watch this space, and if any of you are interested in getting involved in that work, please get in touch with me. If you have any ideas, please do share them. As I say, we have started this work. We're pushing it as much as we can and as quickly as we can, and hopefully you will get more information on this in the next few weeks. So at this point in the talk, I am going to change direction somewhat. So we're going to take a direction towards the Rocky booklet. So this is obviously something that has been part of the Dundee curriculum since I was a medical student, and that wasn't last year. You may notice that there's a change in the appearance of the Rocky booklet that's coming in this year, and that is that we've changed the name from the Record of Clinical Experience to the Roadmap of Clinical Experience. So what the Rocky booklet is made up of is, it was a real mix of experiences, different types of care, different types of investigations that the students in 4th and 5th year would try and get signatures to prove that they'd ever seen or they had done something. Whenever I took up post, I recognised that the Rocky booklet was full of some outdated components that we no longer did, and also wasn't really valid in the context of COVID, and that our students may struggle to get access to some of the components. So I've been liaising very closely with our block leads, and we have revised the structure and the content of the Rocky booklet. I have reorganised it into making a roadmap of the bits and pieces of experience that the students will need for the next couple of years, that mean that on day one of FY jobs, they know how to do the job. Okay, so they will have to gain experience in the clinical care of an unwell, deteriorating adult, and that's got many different components to it. They'll need to be able to prove that they've done some prescribing in a mock simulated environment, that they'll have seen the types of investigations that we want them to be able to explain to the patients. So that is coming your way, and the changes that you will see is that on some of the components, particularly where the students are being asked to do something or perform a task, you'll be asked to just give a little bit of written feedback within the Rocky. So rather than just signing it off, we are encouraging you to just give brief feedback to the students. Our students thrive on feedback. It drives their learning. Nothing complex, but just a few words. So that will be coming your way. Now, at this point, I'm going to make one more comment, and then I'm going to hand over to Lisa, who's going to give you another update. But Jordan Napier, who is our Staff Development Officer, has asked me to add the shameless link for blended learning. I'm sure lots of you still have ongoing questions about blended learning and how you can access the different IT systems that you need, what it means. So if you need to have any further training on that, there are a series of workshops available, and that is the link to the website that will give you all the information that you need. But at this point, that's me done, and I'm going to hand over to Lisa.
Okay, thanks for that, Jo. So in my role as the lead for ScotGem Clinical Interactions and the Skills Passport lead for the whole 5 years for the Dundee cohort, we've been working very closely with Jo, with Clinical Skills team, to develop a procedural skills passport. I've just got about 8 slides, and in those 8 slides, I'm going to describe to you what the passport is, why we've got it, who can complete it, and how it works. So I'll just move on then. So the procedural skills passport is going to provide a formal record to show that a student has reached a particular level of competence in procedural tasks. Now, it's a very small number of procedural tasks that are included in this passport. It's specifically a small number, about 20 skills, that are required from the GMC that a student must be competent at by the time they graduate. And so these very specific skills that I'm sure you'll all recognise are essential skills for a graduating doctor have now been collected into the procedural skills passport and aren't in the roadmap of clinical experience anymore. And the purpose of this is that we want to be able to allow students access to care delivery with patients, but we also need to give you confidence that when the students are engaging with clinical care, that you know what level they're functioning at and whether you can trust them and how much supervision they'll need for any specific task. So we want the passport to help you make these entrustment decisions and to reassure both the university and the GMC that students have reached a minimum standard of competence. So this is new for this year. Now, one of the drivers behind this is that we will have students who could be in any health board area in Scotland. And if we limit knowledge of the procedural skills passport or the ability to supervise a student just to those who consider yourselves faculty or consider yourselves strongly associated with the university, we're really limiting our students' clinical opportunities. So in answer to the who question of who can help the student develop the clinical skills passport, the answer is that anyone competent in the task that the student is focusing on at that point in their skills passport. It could be anyone competent in the task, from a GP in Stranraer to a nurse practitioner in Caithness. And the only specification about who can sign off or who can contribute to the skills passport is that the individual must have knowledge of the task that they do themselves, and they must either have a .ac.uk email address or an nhs.net email address, because that's going to be used as part of how we screen for probity. And I'll come back to that when I talk a little bit more about the process. So that's what it is. This is who can do it. And this is what actually happens in the process. So the skills passport is not designed for a student to keep a record of every single time they do a procedure. So every single time they take blood from a patient, they do not need to record every event. They only need to ask for a record of that event whenever they feel they have reached a specific threshold of competence. And I'll describe the thresholds of competence in due course. So what for you as the clinician will happen is that some of the main drivers for this is to make this as easy for you as the supervising clinician from whatever clinical discipline you are. So the student will ask you to observe them doing a specific procedural skill. You will then observe the student doing this particular procedure, and you together with the student will agree the level of competence that they have achieved. That level of competence might be that they can do this procedure safely in simulation, that they can do this procedure with direct supervision. So that means someone in the room watching what they're doing. And the third level of competence is the student being able to do a procedure with indirect supervision. So the student will ask you to agree what level of competence they're at. You will agree with the student, yes, I think you are at a level where you would be able to do that procedure with indirect supervision. You don't need to have me in the room. I can trust you now that you can do that with a patient with indirect supervision. The student then takes responsibility to record this in the passport. And the passport is, for ScotGem students, it's embedded within a portfolio. For the main cohort of Dundee students, that will be recorded in an electronic document that the student takes responsibility for. So there's no paper, no dog-eared little booklets with scruffy corners to get lost and get misplaced. The student keeps a record of that. And the student's got 7 days in which to record that they've had a supervision event. You will then, what happens under the bonnet at this point is different for the two programs, but essentially what happens at the receiving end for you as the clinician is that you will receive an email, and that email will say, thank you, doctor or practitioner so-and-so for observing this student doing venipuncture with direct supervision on such and such a date. And you need take no further action if that email is a correct record of the experience. there's a little thing at the bottom, just like you get with the bank or with one of your accounts, that said, if this wasn't you, or if this is an incorrect record, could you please reply? And you simply need to do a reply all, and that will generate a reply to the medical school office and to the student themselves, where you would explain why you think this is an incorrect record. So essentially, you don't need to sign anything. You simply need to be willing to give the student your .ac.uk or your nhs.net email address in order to receive that checking email. And that's what we'll use to ensure probity. And this is what the booklet looks like to the student, although you're unlikely to ever actually see this electronic booklet. So I've just picked out 2 examples out of the 20 tasks that they should do. One of them is very simple: take baseline physiological observations. There's a place where a student can record some of their progress notes if they want to, but when they feel they've reached this important threshold, and the threshold is very clearly laid out to the students in the booklet. The threshold is determined by the GMC, the level of competence is determined by the GMC, and the GMC have determined that for a student to be able to take physiological observations and record, that they need to be able to be safe to do that with indirect supervision. Indirect supervision means that you as the clinician might say to the student, okay, I think you could go and see the patient in such and such a location by such and such a name. Please go and take their physiological observations. So indirect supervision means you know where the student is, who they're with, and what they're doing, but you don't need to be in the room actually watching what they do. So these, and then I've shown you an example of number 14, which is preparation and administration of injectable IM and subcutaneous and intravenous drugs, including pre-filled syringes. And the specified level by the GMC that a student should reach by the time of graduation is that they ought to be able to do that with direct supervision. So a student, when they feel they've reached that threshold, records the date and the email address of the person who has supervised them. So we've identified the 3 levels from the GMC as simulation, direct supervision, and indirect supervision. So what we've tried to avoid in design of the skills passport is we don't want this to be excessively burdensome, either for the trainees, for the students, or for the assessors. We don't want to create a burden of extra work for you, and we want to avoid the tick box culture. So once a student has already been signed off as being capable of doing a particular procedure at a particular level of competency, that is then their passport with which they can take into a range of clinical environments, particularly when they're moving between different clinical areas and different environments. And that is essentially their passport to allow them to continue to practice at that level. So it doesn't allow them to stop doing intramuscular injections or stop doing physiological observations. It's simply their passport to allow them to continue to work at that level and to continue to contribute to patient care in that way. And we don't have a one-size-fits-all. We don't specify a specific number of procedures that a student must do in order to pass. We simply ask that the student, in discussion with those who supervise them, identify where these important thresholds are reached, because some students will reach that level of competence with 1 or 2 practice opportunities, and some will need a lot more practice opportunities. So there's no specified number. It's about reaching that minimum threshold. And while feedback is minimum, if they reach the threshold, any student who doesn't reach that required threshold, then verbal feedback is going to be really important for them to identify the areas that they need to work on. The passport will form part of the student summative assessment, but not until very close to graduation, because we want to give them lots of opportunities to record their progress and to develop their progress. So the procedural skills passport will be reviewed each time the student has a portfolio review. So that's 2 formative reviews in 4th year and 1 formative review in 5th year before their summative review of their portfolio towards the end of 5th year, by which stage they must have reached the minimum standard. So we'll be helping to support the students at their review in fourth year to look at their progress, and we'll give them some suggested timelines for all of those three formative reviews across year 4 and year 5. And we'll say, you should have expected to have achieved this procedure at this level, this procedure at this level, and this procedure. And if a student hasn't achieved during those two formative experiences, we'll be supporting them to develop a realistic and achievable plan as to how they're going to reach these standards by the summative at the end of year 5. So I hope that that has given you a flavour. I haven't included the full list of GMC outcomes because that's available. Those of you who are closely involved in teaching will know the things that are on that list, but there's 20 out of the 23 requirements of the GMC. 3 of them we've removed because we don't feel they're suitable for this context, but there are 20 skills altogether, and they include things like venipuncture, cannulation, physiological signs, urinalysis, IM injections, simple wound care, and so on. And if any of you want a full list of that, that'll be really readily accessible through block leads and through teaching faculty. So that's the end of my presentation. So I'll stop sharing now, and I'm not sure whether Tom is going to curate questions or whether Joel's going to. But thanks very much for your attention. I'm happy to take questions about the Skills Passport.
Thanks so much, Lisa. So, Joe, anything else to add at the end, just to tidy up? No, shake your head.
No, no more.
So we have no questions in the chat at all, which means you've submitted everyone into silence, which is good. Anybody have anything they want to speak about? Any? Oh, there is a question. This is from M. Kirkpatrick. Near me teaching, using screen sharing in particular, is there a way of ensuring that patients can be explicitly reassured that their consultation will not be recorded, either through technology or via specific staff and student undertaking? So I suppose what this is talking about is I can use my phone, I just take a video of what's going on this screen. How are we going to just reassure patients that that's not going to happen?
Well, none of the teaching clinics previously have ever been recorded, and I think that's what's been at the nub of some of the discussions around having students joining remotely from home, and that we feel they should be either in the hospital on university premises, either with a tutor or under direct observation, so that we can all see, so that if somebody was about to lift a camera, then it would be very obvious because the entire group would see that. And
I don't want to tread on the toes of Professor McCrimmon, who is in this virtual room, but I would have thought that the medical school's view on anybody who did record a clinical scenario like this without permission would be subject to professionalism processes that are already in place. There's Rory's.
Yes, Tom, sorry I was on the wrong screen. There you go, I'm getting used to technology myself. So you're right, you clearly cannot record something without getting any express permission. I was going to ask a follow-up on question, actually. First of all, to say thank you very much. That was a great presentation from Jonathan and Joanne and Lisa. Really good to see all that activity going on. Jonathan, I was wondering about primary care. I think, as you know, primary care is under a huge pressure at the moment and had to really massively change their work. And we normally would send out 1 or 2 students at a time. And I guess there is the possibility of using Near Me to allow 3 or 4 students from different practices to come together within that environment, which might at least take some of that burden. If a practice had maybe 1 teaching clinic every month, as opposed to having something every week, they could work. Is that something that might be possible?
Absolutely. I think this is a very adaptable format that we can use in all sorts of different ways. You know, we were faced with the issue before the pandemic of having 16 students in a block. The actual natural place for teaching clinic is primary care, I've always felt, because that's where you've, that specialist in the one-to-one encounter. And Near Me, we can get 3 or 4 people to join. So for for groups of that size, it's possible that can link practices. You know, what I want to give people is a framework of a solution that allows them to go, right, I can adapt this and it'll work really well in my area of practice, and we can make this work. But the concentration on is exactly in Joe's terms, the learning event, and building it around a learning event rather than just saying clinical service is really difficult and we need to sort of somehow get some students to watch what we're doing, but to turn these into a learning event.
And can I follow up there, Jonathan? When you set up the clinics, the teaching clinic, did you do that separate from your normal clinic lists? And because,
Yeah.
I mean, I guess the question, as you know, is about space and how you actually bring them in if you've got busy clinics and long waiting lists. But I can imagine if you set up a separate half-day clinic independent of that, maybe, you know, with the on-call consultant or some other way, that it might be one way of doing it.
Absolutely. We set it up as a specific event. We were only seeing 3 new patients over an afternoon. So we're having a very small impact on the clinical workload of the department. But, you know, the students said, you know, they would swap 2 days of sitting in other people's clinics to do 1 half day doing this, because, you know, they found that experience much more valuable to their skills and competencies. And there's lots of subtle ways of changing it that will make a difference to all sorts of areas of practice. So it doesn't need to be a carbon copy of what I've done, but the principles are there that will hopefully, you know, as already you've shown, sparks imagination off in lots of other people and allows them to say, yes, I'm going to build one of these, and there's an outpatient experience part of my block now that works.
Fantastic. And one further thing, sorry, Tom, if I'm asking another one, but I guess it's for Joanne really, and Joe, is that a lot of people are concerned that they're expected to give the perfect blended teaching experience right from day one. But I'm guessing that we're going to allow, yes, of course, that time, and that it's going to be a gradual process over a number of years as we improve them.
Oh, absolutely. And we have given the students kind of forewarning that this year is going to change and it's going to adapt, and we all must be adaptable in our approach to it. And certainly our block leads have done absolutely fantastic work and have been so innovative in what they are delivering. And as their service changes, they will be engaging in different clinical activities. So yes, blended learning, as our curriculum should always be, is a fluid situation. We should always be revising what we're doing and changing, using the things that work, and the things that don't work get removed. So yes, this does not need to be perfect for the beginning of August, or for the middle of August. Yes.
Great, thanks.
A couple more questions in the chat now that I've got rid of Rory. So where are we? Susie has said, will you be including feedback, patient feedback in evaluations, and if so, how?
Again, it'll depend, I think, on the setting in your own block, but we certainly got instant feedback because the patients were there and you escorted them out the room, so you could certainly get verbal feedback there. We didn't formalize it more beforehand, but there's no reason that couldn't be collected. I think the things that people would want to know about is the length of the appointment and the fact that it'll be mainly the student that they are speaking to, but that there's a consultant, tutor or facilitator in the background.
Okay, Iqbal had a question about a technological question which Jordan has taken away for us, and I think she'll sort that out. Cara has mentioned to us that digital professionalism, recording screens, etc., has been added to the student charter, which all the students sign when they join. Fee McFatter has asked, does anyone have an info sheet that's given to the patients in advance and outlines remote student participation? And that, I think, ties in with Kalpana's question about, is there a standard letter sent to near-me clinic appointments and a checklist for students to maintain high professional etiquette during virtual meetings? So
certainly medical records send out information about joining near me. In terms of, I devised a standard letter for the teaching clinics so that they had that expectation. I must admit, some patients obviously never read it and they arrived and were like surprised to see all those students there. That did happen at times, but they were provided with that information in writing. I think it's important. As for seeing all the students there, I think that could be rather daunting for some patients. So it'll depend on the format. I think it'll work best if they can take a history with a student and see one of them and see the tutor for reassurance. They don't need to see everybody, but maybe the tutor does need to see everybody.
Okay.
And can I just come in on that and say that as part of the group, the work that we're doing, we will be looking at creating consenting forms and patient information sheets that you will be able to just lift off the shelf and use for your own clinical areas. So we are driving that from within the medical school, and we'll share it with you once we have them fully formed.
I think that will be very helpful to people to be able to do that. I think Kalpana's question about checklists for students to continue high professional etiquette, I suspect the medical school in terms of the charter and ongoing information will deal with that. Professor Proby says, when will we get on-site IT support to help us with blended learning? This will be essential when the full program gets up and running. I'm not sure whether you're in a position to answer that, either of the three of you.
Not particularly.
I think the person to speak to is probably Jordan. She may.
There are drop-in tilt sessions that have been running on a weekly basis, which are helpful to get to grips with the university technology from people who don't use it every day of the week.
Okay, and Kalpana, just a comment rather than a question, we're trying to record live or provide live demonstrations of surgeries to give students a real-time experience of attending theatre, which I think is a really useful tool. I've learnt in that way for bronchoscopy, for example, where there's 40 of us in a room trying to learn a bronchoscopy technique, whereas doing it remotely, where there's one person actually doing it live to the patient. So that I think is a good innovative way of doing things.
All the same idea, really.
It's all the same idea, as you say. That's it. But it's just getting around to doing it, isn't it? And trying to get the time and effort into putting it into and demonstrably, it's well liked by the students and. So well done for the work you've done, Jonathan. Excellent as always. And I'll bring things to a close then. Thank you to Jo, particularly for pulling this together and volunteering her colleagues to give a grand round. Thanks, Jonathan, a long time no see, and same for Lisa as well. And thank you all for joining. Next week is Jonathan O'Riordan speaking about optic neuritis, as I said at the beginning. So look forward to seeing you then. Thanks very much for your participation. Thanks to the speakers. See you next week.
Thanks, Night.